Hello, I'm Antoni Chan from London, United Kingdom, and I'm here at ACR 23 reporting for Rheum Now, and there have been very interesting presentations today. And today I want to focus in the area of cardiovascular risks, in particular in rheumatoid arthritis. We know that in rheumatoid arthritis there is at least a 1.5 times increase cardiovascular risk in terms of major cardiovascular events or cardiovascular mortality compared to the normal population. And so how have this evolved? Here at the ACR 23 there are two important abstracts from today. Firstly, it's 0387 by Weber, and this looked at the use of highly sensitive CRP measurements, and to see whether these correlated with the outcome of patients, and also using the highly sensitive troponin as well. So when they looked at the aspect of the troponin measurements, and these are measure of myocardial damage, they looked at two groups. Firstly, the people who had high CRP at the beginning of disease, and then over time on the treatment they became low CRP, and on the reverse, people who had low CRP at the beginning and then subsequently had high CRP. And they found that in patients who had the high CRP going to the low CRP had an increased cardiovascular risk, and this correlated with the presence of troponin measurements in the blood. And so they concluded that the use of troponin could be another measure that we could use in order to assess our patients with rheumatoid arthritis in terms of finding out their cardiovascular risk on top of the traditional cardiovascular factors that we know that we use for these patients. So perhaps another marker that we could add into our cardiovascular risk assessment for our patients with rheumatoid arthritis. The second abstract is 391 by Kapuzos and colleagues, and this is about the use of biologic therapies and whether they made an impact in terms of the cardiovascular risks longer term. And these patients were followed up to 15 years, and this was part of the International Cardiovascular Consortium, and they had many patients, over 4,000 patients recruited into this study. And the incidence was to look at the incidence of major cardiovascular events and any ischemic cardiovascular events over a period of time measured in terms of patient years. The main findings from this study was that in patients who were on biological therapies, they had a better clinical outcome. There was a reduction in their major cardiovascular events and also any ischemic cardiovascular events compared to the non-biologic groups, patients who are not treated with biologics. And again, this tells us that there is a positive effect, a protective effect on the use of such therapies to reduce the cardiovascular risks in patients with rheumatoid arthritis. In further analysis, it wasn't just the reduction in the disease activity score, the DAS28, or the inflammation level that conferred the protection. There was also an added benefit that probably came from they consider other factors such as stabilization of the coronary artery plaques, for example, additional protective factors from the use of biologics beyond the traditional reduction in just the inflammation levels. So I think from these two studies today, firstly, assessing our patients using new tools such as the troponins to measure cardiovascular risk on top of our standard cardiovascular risk assessment, and secondly, with a more aggressive treatment of the condition, and also seeing the added benefit of biologic therapies in terms of reducing cardiovascular deaths and risks for our patients. So two important studies from ACR 23 today. Thank you.